So, hello everybody. My name is Dion Filmer. I'm the director of the World Bank's Development Research Group. Welcome to this policy research talk. These talks, as some of you may know, give us an opportunity to present work coming out of the department, the research department, with the goal of sharing the findings with each other, with colleagues inside the bank, as well as others outside of the World Bank. Just welcome our online audiences, both on WebEx as well as on YouTube. Today, my colleague Anja Sautmann, who is a research economist, who actually joined us relatively recently, but she's a research economist in the human development team of the department. She's going to be presenting insights from recent research on healthcare demand and utilization in Mali. Her talk will focus on the allocation of acute curative healthcare and to what extent demand-side policies can affect this allocation. I'm very grateful to have Gaston Sorgo here today as discussant. Gaston is a practice manager in the Health, Nutrition and Population Global Practice of the Human Development Practice Group here at the bank. He joined the World Bank in 1999 and has previously served as a country manager for Mauritania and lead public health specialist and human development sector leader based in Cameroon. Gaston is a physician with a master's of public health from the University of Amsterdam and a doctorate in public health from Harvard University. So the run of show today is going to be, Anja will talk for about 45 minutes, after which we'll hear from Gaston for 10 to 15 minutes, after which we'll have questions and answers from the audience. If you have a question, please use the raised hand function in WebEx or just signal to me in the chat that you have a question and I will call on you. If you're following on YouTube, please put your question in the chat over there and that will get relayed to me. So with that, over to you, Anja.
Thank you so much, Dion. Give me 1 second. I'll share my screen. Is this, can you all see my screen? Great. So yeah, thank you, Dion. Thank you very much for hosting this talk. Thank you, Gaston, for being here as a discussant, and thank you also to the audience for joining us. As Dion said, this talk is about overuse and underuse of acute healthcare with empirical evidence from Mali. And before I go into this evidence, I would like to motivate a little bit why we should care about overuse and underuse, and specifically in acute care. As I'm sure many in the audience know, global health has seen great advances in preventive care in the last 2 decades. And there is something of a policy consensus today that in order to make further significant improvements, we really need to focus attention on providing better care for acute illness in addition to preventive care, acute illness and curative care. Now, unlike in preventive care, however, in curative care, whether and when any given individual needs treatment varies, and it varies based on the person's health status. This health status is often unobserved to the outside observer, but it might even be unknown to some degree to the patient themselves. Many healthcare decisions are made in the home, and oftentimes when you present with some diffuse symptoms, you might not know what your illness exactly is. In this context, misallocation, that is the underuse and overuse of care, is a core challenge for efficiently and with high quality provide acute care. And this misallocation question is also a measurement challenge because, again, as outside observers, as researchers, but also as policymakers, we have to define who needs what type of care and then measure if they actually receive this care. And of course, this allocation question is closely linked to the good health and well-being SDG, which mentions, among other things, pay for performance, sustainable financing, quality of care, and so on. So why look at both underuse and overuse in low and middle income country contexts? For surely, I don't need to motivate the question of underuse. Underuse remains even today a challenging problem despite substantial progress made. Just to give one number, in 2019, 5.2 million children under 5 years have been estimated to have died, mostly from preventable and treatable causes such as diarrhea, malaria, and pneumonia. Part of the policy response to this underuse problem has been a fundamental shift from a user fee model to providing free care for children and mothers in particular. This is a pivot away from the Bamako consensus in 1987. And the same thing has actually happened in Mali, where in 2019, the Ministry of Health announced the intention to provide free children's and mothers' healthcare by 2022. Having said all of this, however, there's at the same time a lot of evidence that there's also an overuse problem. So medication misuse has been documented since at least 1990. There is a WHO medicines use summary report in 2006 that shows some of this evidence. And what the report says, among other things, is that there's substantive overuse of injections and antibiotics, a lot of instances of polypharmacy and so on. Polypharmacy is when the same set of symptoms is treated with treatment for different kinds of illnesses, such as malaria treatment and antibiotics at the same time. More recently, there has been also a lot of experimental and audit study evidence of these misuse and overuse problems. Many of those studies came actually out of the World Bank Research Department, and they show that malaria drugs and antibiotics are overused, and more generally that there's a lot of unnecessary and even harmful treatments and insufficient diagnostics for a variety of conditions. Oftentimes, this evidence shows that this type of overuse is the result of subsidies on the patient side, as well as financial incentives on the doctor side. And this raises the question, if we try to combat underuse by introducing subsidies for patients, could this reinforce financial incentives for providers and lead to greater rates of overtreatment at the same time? So when we think about the allocation of care and the correct use of care, this is certainly a challenging problem. And the reason is that there are multiple and complex decisions involved from the decision to visit a provider through the diagnostic and prescription process to actually purchasing and then adhering to treatment. And as a result, there are also many potential sources of misallocation. On the household side, certainly we are acutely aware that there are financial constraints, meaning that families may not be able to raise funds to cover emergencies and acute care. There might also be informational constraints, for example, because households are unable to assess symptoms or correctly administer treatments. And a general recognized problem in healthcare is that there's often misaligned incentives when allocating care between the government, the funder often of care, but providers, but also caregivers and patients. And these incentives are often due to externalities and uninternalized costs and benefits of care. One thing that reinforces all these issues is that there is a fundamental asymmetric information problem, which is termed in health economics the problem of the informed expert, meaning that there is one person in this process or a very small set of persons, the healthcare provider, who can actually diagnose and assess the illness and make treatment recommendations. And everyone else in the process has to rely on this provider's advice. But this can lead to issues if there is misaligned incentives. Now, what comes on top of this, since there are so many decisions involved, these different issues may interact or mutually reinforce each other. And one example could be that if patients, due to the provider having different interests from them, lack trust, this could lead to a lack of effort on the parts of the providers to diagnose the illness and give specific advice. So in this talk, I'm certainly not going to be able to talk about all of the issues that come in here, but I would like to present you with 3 studies plus one unpublished study from Mali, where we collected experimental evidence on underuse and overuse of curative care. And then I would also like to take the opportunity to point out some new measurement approaches that we've taken. So there's 2 sets of studies. The first 2 papers with my co-authors, Christine Blandel, Sam Brown, and Mark Dean, covers the decision about care at home, specifically children's care at home. And these studies are part of an RCT where we study 2 common policy interventions to improve access to care, specifically subsidies and health information provided by community health workers, CHW for short. What's novel about this study is that we conduct a very detailed home survey where we have 9 weeks of daily health diary data on symptoms, consultations, and so on. And there's 2 papers that I would like to talk about. The first is the actual randomized control trial, RCT. Here we examine the decision to seek care, so the extensive margin of care, should we get care or not, for children under 5. And in order to understand overuse and underuse, we construct illness spells and assess the need for provider evaluation using the community version of the Integrated Management of Childhood Illness Guidelines, IMCI, which are guidelines for community health workers with rule charts that indicate when a child should see a doctor. I'm going to talk much more about these studies. This is more a summary of what I'm going to show you. The second study primarily examines gender differences, but also gives us some insight on overuse and underuse because it looks at antibiotics adherence. And what we do is construct spells of antibiotics treatments and then compare these with WHO guidelines for minimal treatment length. The second set of studies I want to talk about is about behavior during the provider visit. So what happens when you actually go at the clinic? And what we did here is to conduct a randomized controlled trial that isolates the contributors to misallocation of, here specifically, subsidized malaria medication. How we approach the measurement question here is by conducting a clinic survey. We conduct entry and exit interviews, but then we also do a home follow-up where we carry out a malaria test, so we are able to actually see whether patients who have malaria did get treatment and those who didn't have malaria did not get treatment. The first study looks at the first of the 2 cross-randomized interventions in this RCT, where we handed out vouchers for malaria treatments, artemisinin combination therapy, ACTs, either directly to patients or to the provider. And we use the difference between those 2 arms to ask, when doctors have discretion to decide about giving a voucher or not, giving a subsidy or not, do they use that discretion to steer patients towards more or less use? And again, I'm going to talk more about these studies and the results. The second intervention tried to approach this issue from a different angle, and we ask how information can encourage adherence to test results and improve the allocation of malaria treatment. And we did this by providing information on malaria tests, rapid detection test, RDT efficacy, either to doctors through a day-long training or to patients through a short video. Now, to give you a preview of some of the findings and to summarize a little bit how these studies all speak to overuse and underuse, let me summarize for you. We find that in care seeking, underuse, as measured by the IMCI, is definitely alleviated, but by no means eliminated by subsidization. And despite this increase in use that is mostly an alleviation of underuse, there's also a significant share of overuse in those newly created provider visits from the subsidy, around 30%. And on top of this, information does not improve the allocation of care further, information provided by the health workers. Moreover, when we look at the clinic, when costs are low and a subsidy is available, providers seem to fail in their gatekeeping function, keeping prescription medications out of the hands of patients who don't need them. And one significant factor in this seems to be patient pressure, patients who are asking for these medications. We find, among other things, that informed doctors who know, informed in quotation marks, doctors who received the training on RDT tests are better gatekeepers, but this actually leads to a reduction in patient satisfaction. And then finally, on the treatment side, on the adherence to medication side, we find that even after the medication was purchased, here we're looking at antibiotics, but the cost should be low, and yet there is a lot of underuse, and it is even higher for girls than for boys. So this raises a number of questions. Among other things, how do we direct subsidized care to those who need it the most and make sure that resources that are used serve their intended purpose? But in addition, what these pieces of evidence highlight is that there are multiple margins of overuse and underuse, and I will argue that this raises a number of important open questions. For example, do these margins interact and possibly reinforce each other? and then what are actually the net effects on health outcomes of these misallocation issues. So what I'm going to do in the rest of the talk is I'm going to introduce the setting and show you some summary statistics of our samples. And then I'm going to talk about each of the studies in turn, the RCT on subsidies in healthcare community health workers, sorry, the study on overuse of malaria drugs, and then the adherence study for antibiotics. And then I'm going to conclude. So to start with the setting, public health in Mali is provided through decentralized community-based care funded by user fees. This is in accord with the Bamako consensus. And a lot of this care is provided by so-called CESCOMs, community health clinics. And these clinics are commonly used. So 47% of mothers reported in the DHS in Bamako that they took a child with a fever or cough to a CESCOM. And there's around 70 of such clinics and associated reference hospitals all over Bamako. Our malaria overtreatment study was conducted at 60 of these clinics, and we have a census that gives us some insight into what these clinics look like. So they have about 30 patients a day on average. Most of these clinics actually have a basic laboratory where they can conduct microscopy. And many of, all of these CESCOMs, at least in Bamako, in the capital, have a dispensary that has essential medicines available for sale. Around 11 staff have the ability to write prescriptions for things such as malaria treatment. And it should be said, these are doctors and nurses, but also medical interns who staff these clinics after hours. And you can see that there is a resource constraint. Many of these clinics report temporary stockouts, but only in 1.7% of cases, they are really stocked out of all the malaria drugs on a given day. So our samples come from the two RCTs, and the first is the Action for Health RCT that studies the subsidy and community health worker intervention. Here we conducted a home survey with 1,768 children in 642 compounds. A compound is a living unit where several households share some common infrastructure. And in the sample included are all families eligible for the program. This means they have children under 5, they pass a proxy means test, and they lived in the expansion area of Action for Health, which was a program by the health organization Mali Health. The second sample is the clinic data with 2,055 patients with acute systems collected at these 60 CESCOMs in Bamako. And as you can see, these samples are actually fairly similar. So our Action for Health data comes from the household heads, but you can, and the clinic data comes from patients. There is some differences in literacy rates because women generally have lower literacy rates, but you can see overall literacy is low. Only 13% of our Action for Health households have salaried employment. The households are relatively large, but a little bit smaller in the Action for Health program, probably because these are relatively young families. But they are similar in average monthly income per person between 22,000 and 26,000 CFA, so in US dollars, around $40 to $45 per person. And as you can see, at least in Action for Health, this is an urban area. So this means these households live relatively close to the clinic, only around a third of a mile or half a kilometer away on average. So let's start with the first study, care seeking for children. To motivate the original study, what we were interested in is to understand the effects of subsidies and how they affect the allocation of care. Subsidies have the potential to reduce underuse due to access barriers such as credit constraints and incorrect beliefs. But because they monotonically increase use, they may also lead to overuse. And in that case, information may help improve the allocation. And information is here provided by community health workers who visit families bi-weekly and discuss health and symptoms and health needs with parents. In the experiment, we randomize compounds into these two treatment arms. Cross-section, we do a cross-randomization, so some households receive both and some only one of each of the interventions. The first one is the subsidy intervention, where Action for Health pays for clinic user fees for the 5 most common conditions for children under 5, and then the information intervention of the community health worker visits. One puzzle in the literature on these types of interventions is that policies that reduce the cost of acute care often actually have relatively little health outcome effects. And we don't always know why. And so what we did in this paper is that we measure health utilization directly using the diary data I mentioned before against the IMCI benchmark. So what we have to assume in order to define overuse and underuse is that compliance with the IMCI actually is important for health. So in other words, when the IMCI says by the rule chart that a child should seek care, if this child does not receive care, we think of this as underuse of the doctor. And in analyzing this data, we will treat the decision to seek care as basically a stopping problem. The parents make a decision every day watching the illness of their child, whether they should go today or wait for another day to seek care. And the IMCI works kind of in a similar way because it gives guidelines for how long a kid should wait before care should be sought, for example, for things like diarrhea. And so what we do is we use the IMCI to classify a child during an illness spell as either early for care, so you don't yet need care, or care required and care should be sought today or should have been sought in the past. So now for the data collection, we had surveys visit the households 9 months after the Action for Health start. And they constructed detailed health diaries with the mothers. And just to give you an idea, out of about 60 days of illness, 60 days of 60 diary days that we collected for each child, around 16 days, the average child had some symptoms that have not yet received treatment. And the 5 symptoms listed here are the most common symptoms. And you can see that colds and coughing are very, very common among those illness days. And those are not as serious and in many cases do not require care. However, in 32% of cases, there's also a report of unusually hot or cold skin. So in other words, potentially a fever. In 9% of cases, there are more than 3 loose stools, or in other words, diarrhea. And in 5% of cases, the child is reported to vomit everything, which is actually one of the 4 danger signs we collect and would require immediate medical attention. On top of these symptoms records, we have records on doctor consultations and medication purchases. And this is the first impression of how the subsidy has affected care seeking. So you see here that only 89 times our children see a private provider, but 646 times they actually go and see a provider at the SESCOM. And what's striking is that the vast majority of these visits, 508, take place in the groups that received the healthcare subsidy. And you can see part of the reason is, of course, the cost difference between the 2 visits. The costs of a visit are much lower when there is a subsidy. And I should say the costs are always a little lower than the value of care received or the total price of care. And part of the reason is that many households seek outside help to finance their care needs. What you also can see, I'm not going to talk much about this, but you can see that a vast majority of healthcare is actually obtained in from informal providers, informal sources of medication without any consultation of a medical professional. So this slide shows you the main results of this study. What you see here is the 4 treatment groups. On the left side, you see the groups without subsidies, and on the right with the subsidy. And then on the top, you see the groups without the health worker visits, and in the bottom with the health worker visits. We have a total of nearly 4,000 illness spells for these children. And these spells last on average a little over 6 days and have 3 care required days. There's huge amounts of variation. So some reason for the high number of the high average length is actually that there's some real outliers where kids are sick almost the entire period that we interview. But what you see are basically 3 main points. The first is, you see this in the control group even. Sorry, I should say what's on the graph. So on the x-axis, you see the day of the illness spell. And then the two lines represent the probability of seeking care on either a day that is early for care according to the IMCI, or where care is required according to the IMCI. And on the y-axis is the probability of care seeking. And what you see is that the probability of care seeking is certainly a lot higher when care is actually required. What you also see is, going from the left to the right, as these households receive the subsidy, care seeking increases a lot. And this increase is concentrated on care required days, but by no means is care seeking at 100% on care required days. And then finally, what you see is that when you go from top to bottom, that the community health workers actually had surprisingly little effect on care seeking behavior. And in particular, what they do not do is direct children better towards care when care is required versus not receiving care when care is not required. So they do not seem to improve the allocation very much. So to summarize the findings, we estimate these formally with a hazard model, and we find there is an over 5 times higher probability of care on care required days than on early days. So what this seems to indicate is that parents can clearly distinguish differential need for care by child's health status. They just underuse care overall. The subsidy is successful in increasing care seeking. The probability increases by 250%. And as a result of the differential care seeking in care required versus early days, about 70% of the new visits are actually IMCI recommended care, which is good news. However, it is still the case that 71% of care required spells still don't receive any care, even in the subsidy condition when care is almost entirely free. So what we see is that underuse is alleviated but not eliminated by these subsidies. And moreover, because underuse and overuse increase at the same rate, despite the very low probability of overuse on any given early day, there is still a significant share of utilization, share of doctor visits that actually constitute overuse according to the IMCI. And in addition, the information provided by the community health workers does not improve this allocation. So this raises some questions. In particular, how could we direct care better, the subsidized care better towards these care required illness episodes versus care not required episodes? Now, for the second study on patient demand for treatment, this is now a study at the clinic, and we are focusing on prescription and purchasing behavior. The motivation was the policy challenge of overtreatment and wrong treatment obtained at clinic visits, even in very low-resourced settings. And our data gives a good impression of this. So from our home visit data, where we conducted malaria tests, we know that 42% of malaria-negative patients received treatment. And on top, 20% of malaria-negative and 53% of malaria-positive patients received treatment for severe malaria. So to give you an impression, severe malaria is a crisis state of malaria, so to speak. It usually comes with convulsions, organ failure, sometimes coma, and it requires immediate medical, very, very significant medical intervention. It's treated typically with injections and then an immediate referral to the hospital. It is typically estimated that out of all malaria cases, around 10% escalate into severe malaria. And because we interview these patients at home, they were clearly not referred to the hospital. So there's good reason to believe that a lot of this severe treatment is actually overtreatment of some form. Now, the question is this overtreatment driven by providers? The reason why this question is prevalent is that a lot of health economics focuses on the financial incentives for providers to overprescribe and increase the budget of their clinic or increase their own income. There is some evidence in the data for this possibly being the case. First of all, patients in our data do not always, only in about 2/3 of the cases, actually buy a prescription for an antimalarial that they receive. And moreover, severe treatment is over 2 times more expensive than simple treatment, even though, and it is prescribed very often. And a lot of the fees are actually fees for labor, so they would go directly into the clinic salary budget. On the flip side, when you actually ask providers why overprescription happens, they will tell you something different. They will say the patients come to the clinic knowing what they want and they ask for this treatment. And again, we have evidence for this in our data. Before the consultation, 55% of patients we interview believe specifically that they have malaria and need treatment for it. And 57% of our health workers report that they feel pressured to prescribe medications, and oftentimes they mention antimalarials specifically. What's remarkable about this is because these providers have prescription power, this requires to some degree reluctant compliance by them, giving in to the patient's demand against their own better judgment. So in order to test which of these two explanations is prevalent, we conducted a randomized trial where we rotate each clinic through 3 pricing conditions. And the price variation is for the simple treatment, for the malaria treatment that is standard and recommended for simple cases, the artemisinin-based combination therapies. These are simple tablets taken over 3 days. On control days, there are no malaria discounts available at all, but then there is 2 additional interventions. The patient voucher intervention gives out these free vouchers for simple malaria treatment, and these vouchers are directly given to patients. The vouchers are not valid for severe treatment or any treatment that involves injections, and they are received, importantly, before the patient even sees the doctor. So they come into the consultation knowing this treatment is free for them. On doctor voucher days, by contrast, the doctors obtain this exact same voucher. It has the same terms and conditions as in the PV arm. However, they have the discretion to give the voucher to patients as they see fit. The patients do not know in advance that the ACT is free before they consult with the doctor. Now, how does this help us distinguish who drives overtreatment? Well, there are different predictions for treatment effects under the 2 treatment arms. First of all, imagine we give these vouchers for patients. This reduces the cost of simple malaria treatment and keeps the cost of all other treatment the same. So what this should do is it should increase the demand for the simple ACT tablets at the expense of not receiving any malaria treatment or receiving severe treatment, receiving this treatment that involves an injection. Now, from the doctor side, when we give the vouchers to doctors, if they show the voucher to the patient, this should have the exact same effect on patient demand. However, they can decide not to show the voucher to the patient and use their information advantage to steer the patient's demand. And one option they have is they could keep overall demand lower than in the PV condition by not showing the voucher to patients who would otherwise buy no treatment, but showing the voucher, giving the voucher to those who would request severe treatment and thereby reduce demand for severe treatment only. If we see this, this would be evidence of patient-driven overtreatment, patients actually pushing doctors and doctors trying to keep demand low. On the flip side, what they could also do is they can use their information and advantage to increase overall demand. So they could show the voucher, give the voucher to patients who would otherwise not buy treatment and increase purchasing rates and prescription rates, but at the same time not use the voucher for those patients who would otherwise get severe treatment and therefore keep demand for the severe treatment option high. If this is what we see, then we would conclude that the overtreatment we see is doctor-driven and there's a significant push to sell more on the doctor side. So what do we find? Well, we find the overwhelming evidence that there's actually significant patient-driven demand at the margins where we see changes. We find that in the patient voucher arm, significantly more vouchers were used than in the doctor voucher arm, despite prices being the same. We also found that doctors make significantly more antimalarial prescriptions in the patient voucher arm than in the doctor voucher arm. And you can see that there is not a large difference to the control where the price discount was not received at all. And then finally, we find a significant increase corresponding to this prescription increase in antimalarial purchases. So many more patients actually receive an antimalarial in PV over DV. We also see, and this is what I mentioned before, we see that you can see the large difference in purchasing rates in the control group. So many patients actually do not purchase treatment, and there is a significant increase when we receive when vouchers are actually available. Many patients are now able to afford the treatment. So what else do we find? First of all, in contrast to these results on the patient demand side, we find no evidence that there's doctor-driven demand. In particular, we find that both in DV and in PV, the treatment reduces significantly how much severe treatment is used. So doctors substitute patients from the more expensive to the less expensive treatment option. And what we also find in general using our home testing data is that there is a really poor match between treatment and illness in both directions. So some patients who have malaria in the home test did not receive an antimalarial, and many patients, I mentioned this already, who did not have malaria did receive treatment. But what we find in particular is that this illness treatment match is worse in the patient voucher than in the doctor voucher condition, even though there is actually some improvement in the underuse component of this mismatch from greater purchases that result from the fact that in the voucher conditions, treatment is now free. What we also find is, this is the second paper, the unpublished paper that I mentioned earlier, in the intervention where we provided training. When doctors receive additional training on the efficacy of tests and using those tests for making treatment decisions, they actually make better prescriptions. The treatment illness match improves, but we find that this lowers patient satisfaction, which is another piece of evidence that these patients are pushing for more medications. So to summarize, we find that at least some of the overuse observed at the clinic is surprisingly driven by patient demand. We find that information in the form of the training we provided had an effect on the doctor side, but the video we showed, at least on the patient side, did not improve allocation. And what those two things point to is that there is a twin problem, a surprising twin problem, where we observe underuse at the extensive margin, meaning whether care is received at all, whether a patient sees a doctor. But then there's overuse at the intensive margin, namely how much care is actually received. And one way of thinking about this is that there's at least a possibility that these two problems reinforce each other. I mentioned this before. So suppose only a small subset of patients go to the clinic. These might be exactly the patients with the highest, the strongest demand for some kind of powerful treatment. So in order to meet these patients' preferences, the doctors tend to overprescribe, and that makes care on average more expensive. But this could have this paradoxical effect that even fewer people go to the clinic. And on top of this, those who do go to the clinic have less trust in the doctor's recommendations. And that in turn, and this is the subject of the Hussain et al. Paper that just recently came out, this in turn might mean that doctors have less of an incentive to actually put effort into diagnostics and giving good treatment recommendations, but rather they just follow what the patients want because they anticipate that patients will not follow their advice closely anyways. So this is, at this point, of course, we need more evidence that these chains of reasoning hold, but there is at least some reason to be concerned about them. If true, then this is a really challenging policy issue because of the aforementioned informed expert problem. The provider is really the one who diagnoses the patients and knows what treatment is needed, and we rely on the provider to both give medications when needed, but also gatekeep medications that are not needed. And monitoring this behavior would really require observation by yet another qualified provider, and this is just very often not feasible. And so one interesting potential that arises from what we found on our information treatments is that paradoxically, actually empowering providers might here play a role in improving the allocation of care. So the last study is on treatment and adherence, and it originally focused on gender differences in antibiotics treatment adherence, but it also has some things to say on overuse and underuse. So what we do in this paper is we use the same health diary data from before, and we construct antibiotics treatment spells and benchmark exit from the spell or stopping the treatment against WHO recommendations. And we can use our data with all our detailed symptom records and so on to estimate on the one hand the probability of actually starting a treatment spell, and then conditional on having started completing that treatment spell. And we can look at the role of gender and other variables in this decision to end the treatment. The table below just gives you an overview over our antibiotics spell observations. We have a total of 712 instances of antibiotics use in our data. And as you can see, most of the standard recommendations involve essentially 5 days of antibiotics treatment, with some exceptions for specific conditions. So this graph gives you kind of the headline results. It shows on the x-axis again are spell days, and it shows you how many children are still taking the antibiotic on each day. And of course, if this is an antibiotic where the 5-day treatment recommendation holds, we should see 100% use up to day 5. And what we see is that unfortunately that is not at all what we find. The girls in this data set have only about 38% completion rates of antibiotics, and boys have higher rates, but by no means full adherence, but it's a significant difference of 9 to 12% between the two genders. And what we find is, surprisingly, that that this completion advantage for boys accrues almost entirely to the sons of educated household heads. What you see in this graph here is the gender effect, the difference in antibiotics adherence for boys and girls, split up by education level of the household head. The reference category is no formal schooling. And what you see is that in particular in highly educated households, this gender difference exists, whereas in households where the household head is not as highly educated, there is not much of a gender difference. One interpretation of this is that is as follows: education is essentially needed in order to make good adherence decisions. This could be because it comes with higher literacy rates and so on. Household heads are typically much more educated, and they are also typically male. And more generally, there's a huge education gap between women and men in Mali in our data. And what might be happening here is that these male household heads who are able to read and follow the treatment instructions just pay very different attention to the care of girls in their household over the care of boys. And so to summarize, with an eye to overuse and underuse, despite a really low cost of adherence, the antibiotic is already purchased, it's in the hands of the household, there is still significant underuse in the sense that many households do not adhere to the full treatment length. It also seems that the presence of a literate, educated parents matters significantly. And this suggests that there are subtle biases in the use of treatment that may affect other aspects of treatment success that we may not have a lot of information on because they happen in the home and we don't very often see these behaviors. Now, what's really interesting and puzzling and a challenging problem is that we know that there are really high levels of overprescription of antibiotics. We saw the example of malaria, but similar things are true for antibiotics. And I think there is some hint of this in this data. I mentioned there are 712 antibiotic spells. And remember, we only had about 730 formal instances of care in the first place. So a lot of times children are prescribed an antibiotic. So low adherence to the antibiotic treatment recommendation is, of course, underuse in the sense that parents don't follow the treatment instruction. But many of the spells we see may actually constitute overuse in the sense that the child's illness is not caused by bacteria. So the policy problem here is simultaneously make sure that many of these children don't use an antibiotic at all because they don't need it, but then for the other children that they actually adhere to the full treatment recommended length. So to conclude, we have seen that in this decision chain, there are multiple margins of misallocation possible and documented. And what we've also seen is that many of the policy instruments we have are in some ways blunt instruments in the sense that they might address some of these margins of overuse and underuse, but not others. Just to give the example of subsidies, subsidies may help address underuse by bringing more children to the doctor, in our case, underuse at the extensive margin. but they might at the same time exacerbate overuse at the intensive margin, meaning that once the patient does show up at the doctor, they actually receive too much care. What this suggests is that there is a need for additional research. We would like to know in much more detail how different incentives and policy interventions change utilization at these different decision margins. And then it is important to understand actually, and this is something that is in some ways missing here, how do these changes both individually and in the aggregate actually map into what we care most about, namely the welfare of the patients, their health, but also their income and happiness. And what I would like to advocate for in this talk is that we need better and more detailed measurements of the allocation and quality of curative care. Researchers and policymakers already have ways to measure these. For example, in economics research, people have used audits, that is direct observation, as well as standardized patients. So these are trained actors who present with specific conditions and then record what the doctor does in terms of diagnostics and prescriptions. And actually the widespread use of these methods was pioneered by World Bank researchers. But in this talk, I also showed you two potential new approaches. One is to use health diary data of illness and medication spells to understand behavior at home. And the other is to conduct not only facility entry and exit interviews, but combine these with home testing. For malaria, we can actually conduct home tests that can help us assess the match of illness and treatment that actually occurred in this specific doctor consultation. This is all I have. Thank you very much. I'm gonna hand back over to Dion.
Thanks, Anja, for that really detailed and insightful set of results. Which I hope moving over to Gaston now and maybe the discussion. There's some real policy implications here that are kind of hard to grapple with. So Gaston, over to you for 10-15 minutes, and then we'll open up for questions. Just a reminder, if you want to ask a question, either just raise your hand in the chat or signal that you have a question, and I'll come to you later. Gaston, over to you.
Thank you very much, Dion. Anja, you are the author of this study, and would like to thank you for inviting me, Dion, and the entire DEC team for asking me to join this event. I am a practice manager who deals with policy dialogue and operational interventions with our client countries, and I'm working in close to 17 countries in West Africa. So I look at your study with a very practical angle in answering the question, how does this study speak to me? And Anja, really congratulations for having nicely synthesized 4 studies into a concise and excellent presentation that it's very difficult for anybody to grasp the full content and to comment very meaningfully unless you reduce yourself to a specific aspect that you can handle. And that's exactly what I'm going to do. You managed to really address a complex problem because measuring healthcare overuse and underuse depends on the definition of adequate healthcare, which integrates individual preference as well as needs. So some scholars, for example, Vikas Sani, defines operation care as care that is needed, wanted, clinically effective, affordable, socially equitable, and responsible in its use of resources. Of course, this is kind of a challenging definition, obviously, but it doesn't prevent us from really looking at the issue of healthcare overuse and underuse, because overuse and underuse has several implications. Have you mentioned some of them? And I would like to go at a little bit higher level, because you are really focusing on demonstrating what is happening, and what I would like to speak at is at what are the implications in terms of someone like me who is really dealing with operations, and how do I look at those findings that you just brought into the picture. So first, for patient well-being and safety, health systems should, of course, bring solutions, but often we fail to address patients suffering, and even sometimes we create more problems. Like you just mentioned it from the data set. This is really critical. Second, for equity reasons as well, because every time one patient unnecessarily uses a resource, another patient is deprived from the same resources. So very critical and very important. And third, of course, from the economy side, because overuse and underuse imply misuse of equipment and human and financial resources. Particularly, overuse deflects resources from public health and other social spending, and this is aggravated by the lack of adherence to treatment. So in total, we can see that these past years, overuse and underuse have attracted attention of the scientific community and other public health professionals. For example, the Lancet published the Right Care series in 1917, which highlight that overuse occurs across a range of medical specialties. It concerns procedures such as cardiovascular procedures, hysterectomy, etc. And most studies on overuse have been conducted in high-income countries. And although it's increasingly recognized in low-income countries, it's not yet well documented in those settings. So your work fills an important gap in the literature, and it deals with key parts of the subject of inadequate care. You talked about financial barriers to care, drivers of overuse, adherence to treatment, etc. So you have marked my mind with key numbers that you brought into light. And let me just refer to three of them. You concluded in your research that with subsidies, underuse and overuse increase at the same time, at the same rate. That was a surprise to me. Other aspect, you mentioned that 42% of malaria negative patients receive treatment. What a scandal, should I say, as a clinician. And you also highlight the fact that 20% of malaria negative patients and 53% of malaria positive cases receive treatment for severe malaria. That's really a real problem. And more importantly, you concluded that 57% of healthcare workers report pressure to prescribe unnecessary treatment, and that some overuse mostly is driven by patient demand. So I already said that your study fills a gap, but additionally, it's timely and useful for evidence-based decisions, as many countries now aim to achieve universal health coverage, and we at the World Bank are supporting the global and individual country move towards universal health coverage. Now, let me go a little bit deeper into the research. Some part of your results are encouraging, since they show that once financial barriers are removed, demand for care when it's medically indicated increase significantly, which is great. But other parts of your results beg a fundamental question, again, using my perspective as practice manager. And the question is, how can countries achieve the ambitious agenda of universal health coverage while ensuring scarce resources are adequately used, when we also observe that half of health workers in your study were pressured to prescribe unnecessary treatment? We all agree that this is concerning. And by that specific finding, it's raised our attention, because seriously, there's a huge question for all of us. And it's concerning because when you look at the framework of the universal health coverage, of course, it addresses three dimensions, which are population coverage, yes, who is covered, service coverage, which services are covered, and financial coverage, what proportion of the cost is covered. But obviously, one dimension that is maybe missing, certainly, is the issue of the quality. And this is exactly to what your findings are pointing to. Because, and I believe seriously that in our countries, we'll certainly need to develop and adapt strong quality control measures. In particularly, some specific measures will be needed looking at what you have found in your research. First, we need certainly a strong communication for behavior change. And in short, let me say education, because while the principle of universal health coverage includes the need to ensure that all citizens have access to data and information on USA, as part of societal dialogue and participation processes, Yet, your third study highlights that the specific role of education in care decisions. I think we would need to integrate some sort of communication strategies into our approach to make the population realize and understand that universal health coverage is not about getting care simply, but getting care that is needed, that is useful, and that is timely. So this is something we need to think deeply about, because so far, when we help countries, we do not necessarily make this linkage with the issue of the quality that your study has highlighted. Second thing I think we need also to consider is the issue of the shared decision making, as it goes end in end with the first one that I mentioned, the first measure that I mentioned. Shared decision making is a process whereby clinicians collaboratively help patients to reach evidence-informed and value-congruent medical decisions. And several studies have shown that some patients know when care is not needed and that there is a lack of shared decision making in this process. And this is really critical and very important. And again, when we are moving at this pace whereby we can ensure services to the maximum of the population, we need to make sure that decisions are made in a sound manner. So this will call for us really to be more regarding and more attentioning to some of the aspects, because many studies have found, and this is corroborate what you just expressed in your study, that for example, in the US, 17%, meaning that 1 in 6 patients, reported that a healthcare provider recommended a medication, test, or procedure that they felt they didn't need it. And 50% of the adults who had received a recommendation for a test they didn't think they needed will end up getting it anyway. You know, so this is really, even in developed countries, this is happening. So what about our countries where the situation is even worse? So it really says that we need to be more focused and pay more attention to those aspects that you have mentioned in your study. There are more studies on this, for example, in South Africa, just to be close to Africa. Well, patients do not always request antibiotics, and they're willing to discuss with the doctor how to manage the condition without them. Doctors in private clinics often go straight and prescribe to the patient, and they will often go and get the medicines. So those are really critical questions that you have highlighted through your study. So you also mentioned the use of the informed expert. I wouldn't elaborate too much on it, but it's a real question that we have to integrate as well in all whatever we are going to do when we move toward universal health coverage. And there we need really to get some of the initiatives, like such as Choosing Wise, the initiative that promotes patient-physician conversation about unnecessary medical tests and procedures. So the third measure is the resource use monitoring system. And I think that based on what you have shown and demonstrated, definitely we need to be more careful and more looking at what we are doing when we just subsidize services. It's not enough to just pour resources and even drugs into the healthcare facilities. It will not resolve the problem unless we have means to measure and to assess how those is used and to give guidance, correct guidance to the practitioners and also to the clients to get the best from whatever we are putting in the services. So this is something very important. And in many countries, there are already different tools that have been in utilization. We may either adopt or create new ones, but definitely we have something to do around this issue as well. So let me finish by a practical way forward suggestion. So I know it's certainly done, but I would like to see DEC teams reach out more directly to practitioners active on the ground. And what I mean is, for example, I would like to invite you to join my next monthly unit meeting with the staff so that you can present the findings of your research to the staff, gather the comments from the TTLs who are working with the government to increase access to services, and discuss the implications of the findings of your research on the policy and operational ground for World Bank's TTL working in Africa. So this is very critical because this webinar is certainly interesting, but we can go deeper and more into detail with the units and help them really grasp this kind of information. It's so critical, and it's not obvious that people will be exposed to those information. It's so vital, and I'm very happy that I was invited to comment. I wouldn't even look at it, even if I see it passing around. But now that I have the chance to look at it, to listen, and to see I realized how important and critical it is for our entire policy dialogue with the countries. And really, I'm amazed to see this correct and complete implication between research and operation on the ground. So again, having said that, I would like to stop there and welcome the Q&A question. And again, congratulations to you and your team for the work that makes us think about how to effectively use results from field studies to meaningfully increase our chances to achieve universal coverage in our client countries. Thank you very much. Back to you, Deon.
Thanks, Gaston. And based on previous conversations with Anja, I know she'll jump at the opportunity to join you at your upcoming staff meeting, and I know she'll be happy to have the kinds of discussions that you anticipate. And thanks for saying that, because this really is one of the purposes of these talks, is to engage people who might not have paid attention to some of these results, and it gives us an opportunity to highlight them and really engage with the likes of you and others. Anja, before turning it over, do you have any quick reactions to any of the points that Gaston made, or should we go straight to Q&A?
Yeah, let me just say a couple of things. So thanks, Gaston, for your comments, and I really appreciate how passionate you are about this, and agreed with Deon. I would love to join you in discussing this more and with a smaller team. But I think you made two really great points that I want to just quickly comment on. So first of all, you said that, and this is something that I think is true in our setting as well, but you said that there's evidence, at least from the US and Europe, that patients often suspect that their doctors overprescribe. And I think what this speaks to is exactly this issue of trust that I mentioned before. And you have said that you think that it's really important to come to a model of joint communication and establishing trust between patient and provider to improve the allocation of care. And then you've mentioned a second need, and that is monitoring resource use. And I'd like to connect those two a little bit, because I think what we find in our data, at least, and I should say, I mean, these are small studies and they are from one country, from one city. So I think there's the caveat of to what degree we can generalize. But what we find in general is that these providers are clearly interested in their patients' welfare. They are not as guided by financial incentives as maybe some health economic studies suggest, but they do give into patient pressure. And I think one question is, how can we use this to improve care? And I think one thing that has struck me is that in order to establish better communication, greater trust, one other scarce resource is rarely mentioned, and this is time. I think these issues do require time. We see that patients are constrained in that way, because we see that they don't even go to the clinic when the care itself is free. This speaks to some time constraints. But we also know that when a doctor really tries to communicate their insights, their advice to a patient, this actually takes a lot of time to teach the patient what they need to do when they go home and so on. So I agree with your thought that we should have better data collection systems to monitor resource use. But I think this also provides an opportunity perhaps to introduce systems that can not just monitor, but can also facilitate communications and improve processes and save both patients and providers valuable time that they can then use to communicate better about the things that really matter, such as how to use antibiotics when you actually come home with your kid. And I think there is a huge opportunity here. So I remember from my research collection in Mali, from my data collection in Mali, in the first few years, we actually visited a lot of clinics, and we saw how doctors keep track of their visits. They have these beautiful ledgers, handwritten ledgers filled with fountain pen. And all this data in them is basically not used very well for any kind of decision making. And it seems really important when we introduce systems to monitor better, to also use that information for the doctors and for the patient's benefit to actually improve the care that they receive in each visit. Really, yeah, I'm going to stop here. These were my main comments that I was going to make.
Thanks, Anja. Gaston, I'm going to give you a chance to come in a bit later again, sort of maybe after some discussion, unless you really want to come in immediately right now. Or should we just take a few questions and then come back?
No, let us move for the questions, and I'm happy to hear that. And Just to mention that I have a chance to live in Mali for 2 years at the World Bank office, and I was how do I call it, the detail for the operation there. So I have a little sense of what is going there, but it's cut some time ago. Back to you. Thanks.
Okay, great. So there's a couple of questions. I'll just mention the names, and maybe we'll take 3 questions with the 3 people have signaled. I'll go in turn, and then maybe Anja, you can respond in one go. I'm going to take the chair's privilege and actually interject one little question beforehand, which is, on one of your slides, you pointed to the high use of informal care, and you said to me, we're not going to talk about that today, but I'm very curious about what's the content of that. Is that pharmacies? Is that other care? And how does that interact with this kind of care-seeking behavior that we did see? And I realize that's maybe a discussion for another day, but just a little bit of insight on that I think would be useful. So in terms of the questions, Ellen, are you still there? You had 2 interventions, so maybe if you could sort of give each of them briefly. Do you want to turn on your mic, Ellen, and maybe your camera and ask your question?
Sure, Dion. Can you hear me?
Thanks. Yes, we can hear you well.
Okay. Okay, yeah, I feel I'm just gonna repeat now what I already typed, but thanks for the interesting presentation. I was just also like in line with, I think, what Gaston was saying, trying to translate your findings to the operational work that we are sort of engaged in on a daily basis. I work in the global financing facility, so not a specific country, but involved in many operations, especially in West Africa. And I don't know whether I understood sort of your conclusion on the first part well, but to me it sounded like indeed demand-side subsidies make people go more to facilities, but that's not a guarantee that actually care gets better allocated, which resonated. But at the same time, I was thinking, like putting myself in the shoes of a TTL. Oh, so what? Like, what is it then? We seem to be struggling with only supply side strengthening through results-based financing. Demand-side subsidies struggle from this shortcutting. Like, what would be your sort of guidance, or what would the questions be to ask when we're developing a project under a limited timeline and limited resources, and sort of how do you see we could mitigate this? What to watch out for or build into these projects to at least try to alleviate some of these concerns. And then I guess a second related comment to the second part of the presentation, where I fully appreciate the point you're trying to make, that even in low income settings, it's not only about low utilization rates and underuse, but also inefficiencies through overuse. I think probably most of my colleagues would agree with that. But then again, sort of operationally, what do we do with this? If you work in a country like Mali, where overall utilization is still so low for very basic services, and we have limited resources and effort, where are we going to put most of our effort on? I understand. I was thinking, given everything you described on working through community health workers, and that it's really quite a difficult agenda to address, for example, overuse or misuse of antibiotics. It would almost require a project in itself, right? Because it's financial, behavioral, it's a complex thing to change. I even see that in high income countries, it's really a problem. So again, sort of then thinking, do we want to invest in this in countries like Mali? Is this where we get the biggest bang for the buck, given the sort of limited resources? Or should we sort of work on this agenda depending on where countries are and the extent of the problem? Just again, thinking that the low health outcomes you see in a country like Mali are very much driven by the very low use of care, and perhaps not so much by the misuse of care. But you might disagree. I was just wondering what your thoughts were on these sort of more operational questions. But thank you. Over.
Thanks, Ellen. Kuram, are you still there? You had one very specific question. Do you want to ask that? Maybe Kuram. No, Kuram, I see you still on.
Sorry. My question about the overuse of antibiotics, and that is in countries where there is a high level of pollution. Don't you think that the doctors prescribe for overuse of antibiotics to protect the patients and to lessen the effect of illness?
So might they be doing something good anyway by overprescribing because of other conditions? Okay. And then Adana, are you there? Would you like to ask your question? I think Adana may have left. Okay, so Anja, do you want to take those two?
Sure, thank you. Thanks so much for those questions. So Dion, to start with your question on informal care. So you're right, we are seeing a ton of these informal care uses. So we collected absolutely everything. These are peddlers who come to the home with little packets of treatment options. These are market stall visits and so on. What you could also see is that a lot of these informal options had incredibly small costs. So 200 SEPA, that's divide by 500, that's a really small amount in US dollars. So what most of these visits actually involve, or what these purchases involve, are really remedies for symptoms such as Tylenol or ibuprofen. They are not often actual treatment, for example, like antimalarials and antibiotics. Moreover, they are often, if they are labeled an antibiotic, we are not sure what the quality of that care actually is. So we would certainly, when we encourage care use by subsidizing, we really want families first to see a qualified provider to diagnose before we want them to buy anything. But you're certainly right to ask about the interactions of the existence of these informal options and the use of formal care. And the short answer, at least for our data, is that we are just not powered to say much about that. But I think it's a really important question for future research to think about. Now, Ellen, thank you. You asked a lot of really good and interesting questions, important questions. Your first question was, well, now that we know that patients go to the doctor, go to the provider more when we give subsidies, and we've also learned that some of these visits might actually be overused, well, what should we do? I think, well, the first answer is that we had hoped when we studied the Action for Health program that one intervention that could actually improve this allocation would be precisely the visits from these community health workers. This is not the only thing they do, for sure. They also do some prevention and so on. But one of the things that they do is they actually go through the symptom rule charts and try to assess if a child currently needs care. And on top of this, they are also supposed to teach parents how to take better care of their children. For example, how to respond to diarrhea and when the child should see a doctor versus not. Unfortunately, this is not what we find. We did not find that in this particular program, the community health workers improved the allocation. This is certainly not to say that this must be always the case. There could be measures to be taken to improve how community health workers steer the use of formal care. But I think it is fair to say that it is an open question how we could improve the use of care at the home. I also think it is really, you make one important point, that it could be that this utilization problem, this misallocation, is the reason why we don't see as many health effects. But I think it's also fair to say that we don't know that either yet, for sure. So the IMCI has been tested many times in public health contexts, and it has been found to be effective. But the IMCI set of interventions is actually a whole set of things that happen, not only these community health worker visits, but other things as well. And so pinpointing how the exact time when you go see a doctor affects later health outcomes is going to be another open question to answer with more research. So this is not as conclusive an answer, I'm afraid, as you might have hoped for, but I think it's fair to say that there's many things we just don't know yet. You asked the second question, which I think is a really good question, and that is one that I can probably and should probably not answer, and that is the question, how should we prioritize between the two things? You were making the very good point that because underuse is such a big problem, maybe this should be taking priority over any problems of overuse. And I think there's many, many areas and settings where this is definitely true. So Mali itself is just an example. So the study that we conducted is in peri-urban and urban areas where clinics are actually relatively frequent. Most clinics have a provider on staff, a qualified medical trained doctor. They have good opening times and the providers are typically actually present. I think there is a hugely different problem of access in rural areas, for example, and Malian rural areas are certainly a case in point where the clinics are really far And even when you go to the clinic, it might be closed or the provider might not be on site and so on. So these underuse problems, certainly, I'm almost surely thinking that these should take priority. But once we go to urban areas and settings where overuse is more of a potential issue, I think we should also think about overuse. And the reason is simply that resources are so incredibly scarce. You saw the data from some of these clinics in Bamako, where the dispensary, the national dispensary is actually closed, and they have relatively good access. And yet many of these clinics run out of treatment regularly and have stockouts, which means that because some people receive treatment that they didn't need, there will be days where just no pre-treatment is available, and some folks come in and do not get the malaria treatment that they would have needed in order to cure the infection. So I am probably not in a good place to give definitive recommendations of how limited resources in policymaking should be allocated. But I do think that there are potentially mutually reinforcement issues here. And I mentioned one pathway in which this could happen if the quality of care at the clinic is low and overuse or overprescription by providers is really high. This might actually discourage people from coming to the clinic. And it might also lead to greater distrust between providers and patients and overall substantial misuse of resources. So I think of these as joint problems in many ways, and I would advocate for thinking about overuse as well, but I totally take your point that we need to potentially set priorities given how scarce all our resources are. For the last question, Khurram, you asked about potential overuse as a preventive measure, and I think you make a really good point. In fact, for antibiotics, I'm less familiar with exact medical treatment recommendations, but for malaria, it's certainly the case that treatment recommendations have changed over the last few years. So, so originally in malaria endemic countries, the recommendation was actually, especially when testing is not available, to simply treat any fever as if it was a malaria case. And the reason is simply that the downside risk of not treating a malaria case is so much higher than the slight risk of overtreating. However, in recent years, we have become much more attuned to the problem of creating resistances. We are already on the second generation of antimalarials, and first generation antimalarials have often become ineffective. So parasite resistance is a real concern. And malaria treatment recommendations have been updated to really only provide treatment when there has been a test. For antibiotics, this is a much harder problem because it is harder to test for bacterial infections. But the rule of thumb is that giving an antibiotic does not have preventive effects. You really need to have a bacterial infection for an antibiotic to do something for your health. And in fact, we also know that antibiotics generally actually harm the natural bacterial flora of the body. So it is not obvious that giving antibiotics preemptively is particularly helpful for overall health outcomes. Having said that, I think in other contexts besides antibiotics, your point is certainly well taken that when you have little access to diagnostics, overtreatment might be actually the right course of action. And we've seen that in the past. At least in our setting, this is not the case because rapid detection tests are widely available. They should be free for patients, and they are actually Mali's and the WHO's official malaria policy to use before treating. This is, I think I answered all the questions, but do let me know if you have follow-up questions.
You did, and in fact, and in passing, you also answered Adonai's question, which was about community health workers and how, how they could be leveraged, or some alternatives to them could be leveraged to right some of these wrongs. But you answered that in part in response to Alan. So I don't see anybody else raising their hand or asking a question. So I just want to give you a chance. If not, Gaston, I might come back to you just for a closing comment if you had one before we sign off. See, there's nobody asking to ask a question. So Gaston, would you like to, and then Anja, I'll give you the very, very final word. But Gaston, did you have any final comments and reflections?
No, okay. Thank you very much for giving me the opportunity to join this meeting. As I said, I'm amazed to see how relevant those discussions are really for us on the ground. And to go a little bit further, I would even start asking myself, how can we really get a better linkage between DEC and operations? Because yes, it's good to be connected at the end of the research to get the result, our findings, and to discuss them. But to what extent can we maybe have more, I wouldn't say involvement because it may be too much, but at least certainly there was some kind of communication or things with the teams in the country, for example, in Mali. But I would love to see the Mali team join this kind of discussion. So it doesn't look like there was many of them around. Well, it's very critical and very important for them. So how can we try to improve this kind of communication so that we have the team, particularly those who are sitting in those countries where the studies are done, so that they can be part of the process. So just a comment that I would like to make. Again, thank you very much for this opportunity. I do appreciate your conclusion when you mentioned the need for more research and the issue of measurements. And again, we can, even if it's a small scale studies, we can already talk about policy implication, because honestly, I do believe that the numbers speaks quite loudly for us and for teams on the ground, because those kind of references are very useful for our papers, for our documents, for our policy discussions, etc. So yes, this is certainly part of the question that we can start addressing, even with a small study. So what can be the possible policy implication with this kind of information that we have gathered? So this is something I think we may also add it and try to discuss it as well. So that's what I would like to add. Again, thank you for inviting me. It's a real pleasure, and I really appreciate it. And we'll get together for the presentation to my unit. Thank you very much. Back to you.
Thanks, Gaston. Anja, any last final words?
Yeah, just to say thank you so much, Gaston. I really appreciate it. And I agree with you. There's both a need to communicate these results further, and also to think about working together to design additional studies and additional research that really serves operational purpose. I do want to say that I conducted all of these studies before I actually came to the World Bank. So all the data collection was done before I was a member of DEC-RG. I was a professor at Brown University before, and that's where all this research program started. But I'm really excited to get more involved in the work that's actually done here, and have the chance to talk more about these open policy questions, and hopefully find solutions as well, and not just point out the many issues we've seen. Thank you.
Thanks, Anja. No, that's exactly, I think that's exactly what this kind of session is supposed to try to do, is to create these linkages that then we can follow up with, you can follow up with, and others too. So with that, I'm going to close the session. Thank you, Anja, for a fantastic presentation, really insightful data and analysis, and a lot of questions and some solutions as you drew out in the Q&A, but also a lot of food for thought. And then thank you, Gaston, as well, for really interesting reflections and reactions, and great to we'll take you up on your invitation to come and join and work proactively with your teams. And then thank you all of you for joining and for the really interesting questions. Ryan has just put in the chat a link with all the materials, the presentation, the video will be posted there afterwards. You can share with others who weren't able to join today. So once again, thank you, everybody, and congratulations, and have a good rest of your day. Bye-bye.
Thank you very much. Bye-bye. Congratulations again. Thanks.
Thank you very much. It was a great pleasure. Thank you.
Bye-bye.
Bye-bye.